Good afternoon, and thank you for joining us today for our briefing. Is your practice prepared for 2021 EM changes? I'm Tricia Rogers, and I'm the Program Officer for the Northern Virginia Health Foundation. For those of you who are not familiar with the Health Foundation, we are the only health philanthropy in Northern Virginia that supports health-related programs and health-related initiatives throughout the region. Now, I know that many of you attended the webinar earlier this year when our expert friends from Rosen, Sapperstein, and Friedlander walked us through important changes in telehealth billing. We're pleased today to welcome back Denise Walsh and Marie Polino from RS&F, and they're going to be talking about the new guidelines and code descriptor changes that are going to be taking effect in just a few weeks, January 1st, as a matter of fact. During the session, Marie and Denise are going to share with you how you can prepare your practice and your providers for these changes. And they have developed a number of scenarios that they are going to walk you through that we think you'll find particularly helpful. A few housekeeping things before we begin. First, this presentation is being recorded, and it and the presenter slides will be posted on the Northern Virginia Health Foundation's website. We will be taking questions after the presentation, but as questions occur to you during it, please submit them in the chat box. Also, at the conclusion of the webinar, you will see a survey as you're trying to close out the screen, and we ask you to please take a few moments to complete the survey. And with that, Denise, I'm going to turn it over to you.
Thank you, Tricia. Good afternoon, everyone, and welcome to today's webinar, Preparing Your Practice for the 2021 E&M Documentation and Coding Changes. My name is Denise Walsh, and I'm a Senior Consultant with RS&F. RS&F provides numerous healthcare services to help practices navigate through the ever-changing world of healthcare. We not only work with large practices and healthcare organizations, we are there to assist solo practitioners as well. As Tricia said, please remember, if you have any questions, put them in the chat box during the presentation, and we will answer the questions at the end of the presentation. Any questions that are not addressed, they will be answered, and they will be posted on the Northern Virginia Health Foundation website. And now I'd like to introduce to you the primary speaker for today's webinar, Marie Polino. Marie is a Senior Coding and Reimbursement Specialist with RS&F and has over 35 years in documentation and coding compliant audits. So with that, I turn the presentation over to Marie.
Thank you, Denise, and thank you all for attending today's webinar. And next slide, please. And we're going to start talking a little bit about the history of the E&M coding guidelines. It's been over 25 years since CMS has published documentation regarding the coding guidelines and the criteria to level your services. Now they are made sweeping new changes, and they're very different from the old ones. The old criteria were considered overly complicated already to begin with. The new patients were treated differently than established patients. You had to meet or exceed the criteria in the subcomponents within a key component, meaning you had to determine your level of history based on 3 subcomponents of the history. And then you had to level your final level of code based on the 3 major components within the code. So this is going to be more simplified in the coming changes. Next slide, please. So they've already started some changes to promote patients over paperwork, which has been part of this entire initiative. Already, providers should be taking advantage of having to not do as much personal documentation. In 2020, they made the changes where the provider no longer had to personally document the HPI, and providers can now just verify documentation entered by ancillary staff. Providers can also now just focus on what's pertinent that has changed in the patient's medical record and doesn't have to rely on unnecessary documentation to fill criteria and notes. Next slide, please. So there will be benefits of the new changes, and these were built with these 4 guiding principles of resource-based care. And the intention was to decrease the administrative burden of the documentation and to decrease the complexity of having to determine your level of service. Providers will no longer have to document relevant non-pertinent findings. You will no longer have to describe normal appearances of a patient's head. You will no longer have to document a review of systems. Providers will be instructed to just document what's medically appropriate for physical exams and histories, because those will no longer be considered in leveling the service. And the use of time will be not depending on face-to-face time. Time will include non-face-to-face time, which is also is an indication of the resources utilized by providers within a practice. So payment is resource-based with no direct goal for payment redistribution among specialties. So there is not expected to be a shift in coding patterns based on specialty. Next slide. So there'll be 2 methodologies to determine your level in the upcoming changes. Because we're going to be eliminating the history and physical exam components as a requirement of the level of service, we're now going to be basing the level of service on the medical decision-making component only or time only. And time will no longer be determined if it's 50% of counseling or coordination of care. It's going to be total time. Providers can choose which method to base their code selection on a per visit, per case basis. You can't choose both to determine your level. You need to determine one or the other, and you should select the basis which brings you to the higher level for your coding to make sure that you're optimizing your reimbursement for your service. Next slide. So what won't change is the medical necessity. Medical necessity is still the overarching criteria to report a service. Your auditors will still expect that medical records maintain their integrity and should be completed timely and should be completed accurately and medically appropriate. They're giving an incentive for timeliness because they're only counting total time based on the day of the encounter. And although this history and exam is not going to be leveled to contribute to your final selection, it should be sufficient to support the medical necessity of the medical decision-making, and certainly should be sufficient to support the problems that you are addressing within the encounter. Next slide. So effective January 1st, this coding criteria that we're going to be discussing today and going into detail, this only impacts the office visit and outpatient department E&M code sets, 99201 through 99215. Other hospital services or other site-specific E&M codes will follow the current existing criteria. So you cannot throw that out of your minds. You still have to maintain your education on that if you make hospital rounds or you're working in the ED or have services in a SNF. The current coding criteria and for leveling a service will be maintained for those other site-specific E&M services. One of the things about what will happen in January 1st is that the new patient levels and the established patient levels will be equal for the level. They can be crosswalked because we are only determining them on time or the level of medical decision-making. Next slide. So because we're only basing them on the level of medical decision-making, 99201 will no longer be in the code set. Now, this is something that if you were providing telehealth to new patients, you probably were restricted to 99201 providing telehealth because you couldn't perform more than a straightforward exam on a patient. Now with your telehealth visits, because you can level your service based on total time on the encounter or the medical decision making, you'll be able to reach higher levels of service. Also, when we're talking about time, the total time is the time spent by the billing provider. Also, the big change for coming up in January 1st is the old descriptions will be greatly reduced. Next slide. So the structure of the new E&M codes for the office visits looks like this. This is a sample for 99204, but basically each level will indicate that an appropriate history or physical exam is documented. And then each code will be ascribed its level of medical decision-making, which will still be considered straightforward, low, moderate, or high. And then the specific coding instruction. So you'll have a new time frame for each level of service. So this is much briefer and much easier to comprehend than the old descriptions, which had 7 components that had to be considered when leveling, was a complete paragraph of a description, which you wouldn't have been able to even put on a slide. But there was so much more to consider in the coding of itself. So the idea that coding should be easier, auditors should have an easier time of proofing your coding, that would reduce the need for audits in the future. Next slide. So for the new patients code set, the code range is from just 99202 to 99205. And these are the time frames that go with these code sets. The new patients are similar to the old code sets, except that now you have to reach at least 29 minutes or 30 minutes to get to 99203. And then you have to have a minimum of 45 minutes for a 99204 or a minimum of 60 minutes to code for a 99205. That is with your coding based on time. Next slide. So the established patients, the time frames have been elongated a bit. First, I want to point out that 99211 is a minimal level of service that is not really applicable for physicians or qualified health providers in the new code set. A concept of medical decision-making is not applied to 99211, and this is a code that's meant to be reported by ancillary staff performing a minimal E&M service under the supervision of an attending provider or other qualified healthcare provider. So for healthcare providers, the minimal level should be a 99212. So straightforward, low, moderate, high medical decision-making, and then the time frames for a 99212 for total time, where the old time frame was 10 minutes, now it's 10 to 19 minutes. Low complexity, which used to be 15 minutes of total face-to-face time, is now 20 to 29 minutes of total time, and 30 to 39 minutes for moderate and 40 to 54 minutes for high complexity. So you can't go above high complexity unless you exceed it by time. Next slide, please. So when coding based on time, it's all of the time that you spend pretty much thinking about what you're doing for this encounter. It's preparation for the visit, it's obtaining history, it's obtaining test results, it's making sure the chart is in order, preparing yourself to familiarize with the old records, the time performing a medically appropriate exam, time counseling a patient, time ordering medications, all the personal time spent on the calendar day. If you're one of those providers that open your charts the day before to prepare yourself for the next day's schedule, you may want to rework your schedule so that you can count that time and do it on the day of the encounter when you're coding based on time. Next slide. Additional time services are referring and communicating with other healthcare professionals, your documentation of the clinical encounter. Time documenting is included in the time. If you're dictating, it may go faster than if you're having to type all of your information in. If the time spent independently interpreting results is time to be counted. And then care coordination. Time that you spend directing your medical staff is counted as your time, but not the time that they spend coordinating care for a patient. And again, this is a total time on the day of the encounter. And one of the things that's important about when you're coding based on time is that you need a procedure where you can count this time with interruptions. If you switch between patients while maybe one patient has to change into a gown, or you leave while your assistant performs an EKG, you can't count that time on that patient. So you need a procedure to start and stop your accumulated times, and then by the end of the day, if you're counting based on time, you would have to accumulate that time and level your service. However, because of that, and we're going to get into the other alternative, but my recommendation is that when we get into the medical decision-making, for all of the questions that you may have on tracking time, you probably will more likely be basing your level of service based on medical decision-making. Next slide. So again, you can only, when you're coding at the highest level based on time, you can get there based on time or the level of medical decision-making. But if you expend more time based on time, say more time than 60 minutes or 74 minutes for a new patient, or more time than 54 minutes for an established patient, there is an add-on code for each incremental 15 minutes rather. So if it's an add-on code where the only base code is a 99205 or a 99215. There is a procedure code that if you have extended time because the work of this encounter does go to the following calendar day, or you're of a specialty or you get extended records to review ahead of time, there is a code 99358 that can be used to report extended time before or after a direct face-to-face encounter, which for the new coding purposes would be billed on a different calendar date. That code is 99358. Not all payers cover it, but it is the only alternative to coding based on time on a separate calendar date. Coding based on medical decision-making, it doesn't matter which date that medical decision-making occurs. Next slide. So to report the additional time, you would report the base level of the code, the 99205 or the 99215, and then you would add on the 99417 with the appropriate number of units to report the duration of the additional time. And that's 1 unit per 15 minutes of additional time. And that concludes the times portion. Next slide, please. So the alternative to time is medical decision-making. And medical decision-making is still somewhat complex, but it has changed drastically in how it is to be leveled. So there are still 3 components, and you will still need to determine your final level of medical decision-making based on meeting or exceeding the level in 2 out of the 3 elements of medical decision-making. The descriptors for each level remains the same, being straightforward, low, moderate, or high. And bear in mind that this new set of medical decision-making only applies to your office visits or outpatient hospital department visits. Next slide. So there are 3 components of medical decision-making, of which the next slides we're going to go into the detail of the new definitions and the new criteria to level these components. But the old definitions will expire for the office visits as of 12/31/20, and the new ones will take effect on January 1st. There has been no discussion of any delays in this program due to the pandemic. So you do need to be prepared for leveling your office visits come January. So it used to be the first component, the number of diagnoses or management options, is now going to be the number and complexity of problems addressed. So it's not so much also the number, but the focus is going to be on the complexity. And it's going to be important that you determine and you learn the new definitions that will level the complexity associated with the problem. The second component is the amount, which used to be the amount or complexity of data to be reviewed, is going to now be the amount and or complexity of data to be reviewed and analyzed. And the way that this component was scored in the previous criteria is drastically changed so that you will be able to score higher relatively sooner with less data under the new criteria. So it'll be important to understand the difference between the old and the new criteria. And then the risk component, which used to be associated with either the presenting problem, diagnostic test order, or management options, is now the risk associated with the complications or morbidity or mortality of patient management. So risk is now associated with how ill or severe the patient's illness is and the management options associated with that illness. Next slide. So in order to make this easier and for clarification purposes, they have added definitions to discuss the medical decision-making and to instruct providers. So when we were talking about the number of problems addressed, first, the problems were defined as any disease, condition, or illness, reason for encounter, the sign, symptom, finding, or complaint, the trigger for why the patient is there, each problem being separate. And then they were only going to be counting problems addressed. So the problem has to be evaluated or considered for treatment or treated in this encounter. The mere presence of a comorbidity or the mere presence of a condition in the patient's problem list does not necessarily add to the patient's complexity unless it is discussed or considered in the treatment or management. So it has to be documented as being referred to or referenced in the current encounter to consider the number of problems addressed within the encounter. Next slide. So they have also now expanded these definitions to define the complexity of a problem. So a minimal problem is one that does not even require medical decision-making or the presence of a physician or a qualified healthcare provider. So when we're talking about these definitions, we're thinking of levels 2 through level 5. We're not considering 99211, the minimal problem, which is not to be confused with minimal risk. So the next definition is a self-limited or minor problem, one that would run its own course, that's transient in nature and is not likely to alter permanently the patient's healthcare status. This is typically a problem where if the patient did not come in, there would have been no occurrence or maloccurrence related to the problem. It would resolve by itself. An acute uncomplicated illness or injury is one with low risk of morbidity for which treatment is considered, where a full recovery would be expected to be made with the prescribed treatment. Examples of an acute uncomplicated illness, they do not offer an exhaustive list, but the guidance mentions things like cystitis, allergic rhinitis, simple spraying. So these are primarily problems that are minimal, related to one single body area or organ system, and easily treated or treated with rest and require minimal diagnostic testing. Next slide. They've defined a stable chronic illness as a problem that has an expected duration of at least 1 year or until the patient's death. And a stable problem is defined that the patient is at their treatment goal. So they do not define unstable. They add the definition for a chronic illness with exacerbation, progression, or side effects of treatment. So basically, when providers think of their patient's illness, their chronic illness as stable or unstable, anything that is not stable or considered stable would fall in with this category. If they're not at their treatment goal, they're in a progression of the disease or an exacerbation. If a patient has hypertension and their measurements are abnormal, but they're the same from month to month, that would not be considered stable because they are not at their treatment goal. And then an undiagnosed new problem is a level of problem where you're working with a differential diagnosis. The condition may likely result in a high risk of morbidity without treatment, but until you have that definition, you don't know. And the example, they only provide one example of this, which is a breast lump. So I think you can translate that to any condition where you might have to rule out a serious disease or cancer would be at this level where it falls into the medical decision-making grid of an undiagnosed new problem with uncertain prognosis. Next slide. An acute illness with systemic symptoms is one that causes symptoms in other body areas or organ systems. Multiple acute complicated illnesses could be considered an acute illness with systemic symptoms because you have to deal with the organ systems that are unrelated to maybe where the primary chief complaint is. An acute complicated injury is one that requires an evaluation of other body symptoms. An example would be a head injury with a brief loss of consciousness. Injuries that are not life-threatening, but are maybe in multiple body parts, multiple sites, need additional diagnostic workup would be an acute complicated injury. And then a chronic illness with severe exacerbation of progression or side effects of treatment is defined as a severe exacerbation which has a significant risk of morbidity or mortality. Now, the operative word here is severe. So that's something that the provider will need to document the severity of the symptoms occurring in the patient. Next slide. So those definitions are ascribed to the levels of straightforward, low, moderate. So this is the first column of the table of medical decision-making. So when it's the number and complexity of problems, level 2 would be one self-limited or minor problem. Again, that would be like a minor rash, a cold, something that the patient did not need to come in for. Low complexity would be 2 or more self-limited minor problems, or one stable chronic illness, well-controlled hypertension, or well-controlled diabetes. One very well-controlled chronic illness would be considered low complexity, whether it's new to you or established, which is something that's different from the old criteria. A patient that came into you with a new problem that you had not seen them before, if it was stable or not, would at least be a level 4 before. And one acute uncomplicated illness or injury would be considered low complexity. And again, so low complexity would be like otitis media, a simple sprain, or just one chronic condition. Next slide. So moderate complexity, our 99214s or 99204s, are now one or more chronic illnesses where they are not at their treatment goal, where they are considered worsening or progressing. 2 or more stable chronic illnesses will be considered moderate complexity. A patient with well-controlled diabetes or well-controlled hypertension is automatically, for this component, going to be moderate complexity. So one of the things it kind of asks the question is, if a patient who's obese but doesn't have hypertension or diabetes yet, would that be considered one or more chronic illness that's unstable? And technically it could be, if a patient their obesity is leading them to a condition of prediabetes. Also, an acute illness with systemic symptoms or an acute complicated injury, those two in and of themselves would be considered moderate complexity of problem. Next slide. And then high complexity would be one or more chronic illness with a severe exacerbation, or one acute illness or a chronic illness that poses a threat to life or bodily function. So this would be also an acute injury that would pose a threat to life or bodily function. So an injury that would require emergency surgery, an illness that where you're considering hospitalization. It could be one or more problems, but when you're at that level for this component of medical decision-making, those would be considered high complexity. Next slide. So the second component of medical decision-making is the amount of data to be reviewed or analyzed. And they also added some definitions to help define the terminology in leveling this component of medical decision-making. They also have created categories for this component of medical decision-making, so that the types of data within each category might switch, but you have to meet multiple types of data in the levels to determine your level and to achieve a higher complexity. So that's why they created categories. But each category doesn't necessarily have a definition of what's in that category. Next slide. So when we talk about tests, we're talking about any test, whether it's imaging, laboratory, psychometric, a physiologic test, electrophysiologic test. If that test is reportable with a CPT code, that counts as a single test. In the current definitions or scoring for the complexity of data, you would get, say, 2 points under tests if you ordered labs and imaging. If you ordered 4 laboratory tests, you would only get 1 point in the old scoring mechanism of qualifying the complexity of your data. Now, if you order 5 laboratory tests, you can count them as 5 documents, which gets you to a higher level of complexity and is much more realistic in determining the amount and complexity of data to be reviewed. So when you're documenting your tests that you're ordering or reviewing, it's best to document, if you can, the CPT code, which many EMRs do associate the name of a test with the CPT code. That will help you to determine how many tests you're reviewing, or to at least name the test. Like, instead of saying I'm getting labs, say you're getting a CBC, a metabolic panel, and cultures of different sites, or serology. It's best to be specific if your EMR does not track each test by its own code. Sources that are external is an important concept. So if you're looking at records and communications and test results that are from an external physician, they have to be from providers that are not within your organization, or are within, if they are in your organization, they're from a different specialty. And if you're having a conversation with those, with those providers, it would be a healthcare provider who interpreted a test, a healthcare provider who is in your group but is of a different specialty, or at the same specialty but outside of your group. If you have to talk to their primary care, or you need to talk to a physician that you're thinking of referring a patient to, those are considered external sources. Next slide. So the independent historian is considered as a data element in this component. And an independent historian is any third-party person or device, if you're using a machine for like a TTY or a telephone interpreter, a third party that provides significant additional history that is required to determine an accurate history or to re-verify a history. If a person is just repeating or confirming exactly what the patient is saying, you wouldn't really count it. Except in the case of an interpreter, you can't make sense of what the patient is telling you in a different language if you don't understand it. So in that sense, that interpreter would count as an independent historian. If you have multiple independent historians, you can count each one. An independent interpretation is defined as when the provider is interpreting a test by viewing the raw data or specimen that has been performed and billed by another provider, but you look at the actual data or the image and interpret it yourself. That is considered an independent interpretation, and it can only be counted by you if you are not reporting it separately. If you order an EKG, you do it in-house and then you read the EKG, you only can count that as a test that you have ordered. Or if the patient comes with an EKG and it's already been billed, if you're reinterpreting it from the billing provider, you could count that. And then discussion of management is having a phone conversation or with other professionals involved in the case, which doesn't necessarily have to be healthcare professionals, but maybe a teacher, a parole officer, a case manager, people that impact the management of that patient, or that are integral to that patient undergoing the treatment that you're prescribing. Next slide. So those definitions are used to determine the level of data. So the straightforward complexity or straightforward level of medical decision-making for this component is no data or none, or minimal being only one test. When to reach low complexity in this component, you need only have one element from one or the other category. And at this level, they have put tests in one category or documents in one category, and they put the independent historian in another category. So for this level, this means that you only need 2 tests because you have to meet at least 2 of the following in category 1. So you have to review, say, one document from an external source and review or order 1 test. And it doesn't matter what kind of test it is. You only need 2 points in this category to meet low complexity. Or it would be an assessment requiring an independent historian. So this means that say with pediatricians, which is just a great easy example, the fact that the patient, the parent is giving the history, you don't have to order any tests to reach low complexity for this component. It's one or the other for low complexity. So a 99213 is very easy to reach in this category, where this category historically was very low because in order to get 2 points, you had to have lab tests and imaging tests and x-rays to get to low complexity in this category. And then, or you had to add on the independent historian or the interpretation of tests. Next slide. So for moderate complexity, you still need to just satisfy the criteria in any one of these 3 categories. So it gets a little complex because you have to look at what the 3 categories are when you're calculating your level for this component. But it's just one of any 3 of these categories. And so it's now 3 or more tests or documents or independent historians from it in a patient's service. So say 2 lab tests and a parent giving the history of the presenting illness would be moderate complexity. If you order just 3 lab tests, you're now at moderate complexity, where before that would have been straightforward complexity to order 3 lab tests. If you order the tests, and this is a point I want to make clear for this component, when you're ordering the tests at one encounter, you're getting the credit for reviewing the tests in the same encounter, in that same encounter that you're ordering it. Whereas with the old criteria, you could order the tests on one visit and then get points per se for reviewing the tests at the follow-up visit. So now you only get the points for when you order the tests that assumes you're going to reviewing them. So you would count reviewing tests in this category as reviewing tests that were ordered by somebody else. Unless you ordered them prior to the patient coming, then you would count the interpretation or the reviewing of the test results. So it's only 3 or more of unique tests or documents or histories, or it's an independent interpretation of a test performed by another provider, or it's a discussion of management or test interpretation with an external provider or appropriate source. So you have to meet just one of the categories, meet the level in one of the categories. It may be no tests that you reviewed, but the patient came with films and you're reinterpreting them. Or it's just that you've had a phone conversation with the patient's primary care provider who's referring them to you, but you're not ordering any further tests. That would be considered moderate complexity for this component of medical decision-making. Next slide. Then for high complexity for this component of medical decision-making, you have to meet the criteria in 2 out of the 3 categories. So it has to be at least 3 tests or documents that you've ordered, reviewed, or an independent historian, any 3 from those bullet points in category 1, plus independent interpretation of a test performed, or the 3 tests and discussion of management or test interpretation. Or it could be just an independent interpretation and a discussion of management. So in this component for high complexity, you have to meet the criteria in 2 out of the 3 categories. Next slide. So now we're talking about the 3rd component, which is the level of risk. Where in the old criteria, there was the 3-columned table of risk. So that table is no longer applicable for determining the level of risk for this code set. So when we're talking about risk, we're talking about the risk of morbidity and mortality of patient management. So it's the risk associated with the severity of the disease and how it's going to be when it's appropriately treated. And the risk includes the medical decision-making related to the need to have the test or not, or to have the treatment or not have the treatment. So, and this concept is also called shared medical decision-making. So when you have these discussions with your patients, they don't have to accept the treatment, but the risk is considered because you're having the conversation and the risk is applied. And you'll have to gauge that level of risk with these management options and the conditions for which you're treating your patient. And the risk of the morbidity. So morbidity is defined as a state of illness or functional impairment that is expected to be of substantial duration, during which function is limited, quality of life is impaired, or there's organ damage that may or may not be transient despite treatment. So you'll have to gauge that level of morbidity that's associated with the patient's illness and the treatment of that illness. Next slide. So they've also added a definition and a kind of a new concept in the guidance for the risk of complications and or morbidity, and that is the social determinants of health. So these are economic and social conditions that influence the patient's or the community's health status. So food or housing insecurity would add to the risk to the patient's management. And this is ascribed a moderate complexity if a condition is present that is qualified as a social determinant of a patient's health. Now, these guidelines were written pre-pandemic, and I believe now that there are many social factors going on during this public health emergency and in the course of this pandemic that are affecting patients in a social way that are impacting their health standard. They've also further defined drug therapy requiring intensive monitoring for toxicity. So this carries a level of risk that is considered high risk when a patient is given drugs that they have to be monitored for the effect of the drug and not the therapeutic effect of the drug, but the effect how the drug might be causing other illnesses. So they don't publish a list of these drugs, they never have, but they have now at least defined that if you're monitoring a patient for side effects or organ damage while they're taking these drugs, the monitoring could be long-term or short-term, and then if it's long-term, it has to occur no less than 4 times per year. Next slide. So those terms and definitions as applied to the levels for this component of medical decision-making. So straightforward level 2, would mean that there was minimal risk for morbidity or diagnostic testing or treatment. So maybe where the riskiest thing that you're ordering for this patient, oh, let's take a lab test to see if this patient's really got an infection. That would be minimal risk to a management option. They don't maybe, they're coming in for an STD check. They've got no symptoms. Oh, we'll just take some lab tests. So that's kind of like low risk at this point. And no treatment offered because the patient's completely asymptomatic. So low risk would be over-the-counter drugs, superficial biopsies, low risk of morbidity to the treatment and the outcome of the problem. So minor surgery with no identified patient or procedure risk factors is considered low risk. When we're talking minor surgery or considering surgery that is only as invasive into subcutaneous tissues, where the physical therapy would be considered low risk patient management. Pulmonary function tests or imaging studies with contrast are given examples as low risk patient management. Next slide. And then moderate risk would be ascribed to therapies that include prescription drug management. Therapies that discuss a decision regarding minor surgery with identified patient risk factors or procedure risk factors. A decision regarding major surgery without identified risk factors. Diagnosis or treatment of significantly limited by social determinants of health. If a patient is homeless at the time of your diagnosis or treatment, or is unable to obtain their medicines because they're out of their job, or is unable to, maybe that's even over-the-counter medications. But patients suffering from social determinants of health is going to elevate the complexity of medical decision makings. It's going to elevate that risk to moderate. And then physiologic tests under stress are considered a moderate risk management option, or cardiovascular imaging studies with contrast and no risk factors are considered moderate risk. And again, just discussion of these options, whether the patient has them or not, you would still consider them at this level. They don't have to proceed with the treatment. Next slide. And then high risk of complications is considered for drug therapy requiring intensive monitoring for toxicity, discussion or a decision regarding elective major surgery with identified patient or procedure risk factors, a decision regarding emergency major surgery, decision regarding hospitalization. You may have a conversation with a patient that you're considering hospitalizing them, but because they have proper care and someone to monitor their condition at home, you decide to keep them at home until further notice or until the symptoms abate or numbers get better. They don't have to actually go to the hospital, but it has to be a discussion. A decision not to resuscitate or to de-escalate care because of a poor prognosis elevates the problem to a high risk of complications or morbidity. And management options such as a cardiac electrophysiologic tests are considered high risk, and diagnostic endoscopies with identified risk factors would be considered high risk management options. Next slide. So putting it all together, this table, which is just half of the table of the medical decision-making grid, I know this is difficult to read, we'll be including a full 2-page handout with a slide deck will be distributed after the webinar. But again, the medical decision-making has to be grid-like in appearance because you have to meet or exceed the level in 2 out of the 3 components. So when you're leveling from left to right, you know you've got to have the same, you've got to meet the level in 2 out of the 3 levels of the 3 columns. So low complexity would be just 1 stable chronic illness with 2 lab tests, and that's it. You don't even have to go to the 3rd column. Next slide. And then for moderate and high, it's more complicated. And again, you have to reference the tool or use maybe a coding tool that your EMR might have, or you can use online. We do have a resource link to a coding tool on the American Academy of Procedural Coders at the end of this webinar. But you'll want to look at your problems and walk them through this medical decision-making grid and qualify them at which level you are in at least 2 out of the 3 columns. So to code for level high risk, you have to have 1 or more chronic illnesses with a severe exacerbation. And you have to have, say, drug therapy requiring intensive monitoring for toxicity. So an example could be somebody with severe progressive rheumatoid arthritis who is on highly toxic biologicals to control their condition. You could have a patient maybe with an acute illness that they've come to you and you've decided that their asthma exacerbation is so bad that their oxygen levels are so low, or maybe they're suffering from COVID symptoms. Your pulse oximeter has them at a condition where they need to go to the hospital right away. That would be an example of high complexity medical decision-making. Next slide. So now we're going to go into some scenarios to just kind of review what this might look like in practice. And in this scenario, we've got a 69-year-old male with hypertension and type 2 diabetes with sudden worsening of hearing loss in the left ear over a period of several days. The patient their ear is examined, the provider determines that there is wax, blocking sound waves from reaching the ear, and the provider removes the wax with irrigation and sends the patient on their way. Now, this would be considered a level 2. It's a low risk problem, and actually the E&M compendium qualified impacted cerumen as an acute uncomplicated illness. And I'm assuming that there's probably a very low risk that the patient, would go deaf from the cerumen in their ear, but it's possible that they could suffer from being hard of hearing with the cerumen in their ear. And there's absolutely no data to review, and the risk of the morbidity of rinsing the cerumen out of their ear is minimal. So this would be a 99212 example. Next slide. So for low complexity medical decision-making, and just to reiterate that these coding scenarios are based on the level of medical decision-making and not time. So these could be 5, 10, 15-minute visits, and that's all that you would spend on them. But they're based on the medical decision-making. And in this scenario, we've got a young man who injured his hand. He's accompanied by his girlfriend. The physician evaluates him, orders and interprets an x-ray to make sure that the injury isn't extended to any bones or soft tissue damage beyond the subcutaneous, and advises that a layered closure is all that's needed. So this would be an uncomplicated injury, which is low complexity of a problem addressed. The amount of complexity of data is straightforward. He gets 1 point for ordering the x-ray and gets no point for reading the x-ray, because he's going to be billing for that, or she's going to be billing for that x-ray separately. And then the risk of complication is low because it's minor surgery without risk factors. Next slide. So here we have an example of moderate complexity medical decision-making, where a patient presents with their history of hypertension, diabetes, and high cholesterol. There could be new, or they could be presenting for follow-up. The patient's recordings are stable. There's a discussion of diet. Provider orders 3 tests. Actually, he was ordering 4 tests, but they're all lab tests. But just ordering these 3 simple tests, and the fact that it's 2 stable chronic conditions. We're at moderate complexity for the complexity of problems. We're at moderate complexity for the amount of data to be reviewed. And the risk of complications or morbidity is moderate because they're renewing their prescription medication. So this is a very common, and this would not necessarily be moderate complexity under the old scoring system, but it is now. Next slide, please. So in this scenario for moderate complexity, we have a 5-year-old female presents with upper respiratory symptoms and a sore throat with pain with swallowing. So the mom is giving the history. There's been no associated fever or nausea. Provider examines the head, the ears, nose, and throat and chest. The provider orders a quick strep and a throat culture. The strep comes back positive, and a course of antibiotics is administered. So we've got moderate complexity, even though we've got 1 acute uncomplicated illness, but we've got moderate complexity because we have at least 3 points in the number of tests or independent historians. We've got 2 tests and an independent historian. So we've met the level of moderate complexity for the second component of medical decision-making. And then because we're prescribing antibiotics, we've met moderate complexity for the treatment option, for the risk associated with the treatment option and management of this patient. Next slide. So in this moderate complexity, a 12-year-old with ADHD presents for follow-up of mild symptoms and minimal medication side effects. The patient is accompanied by his mother, and the history is obtained from both. They report that the grades are good, but appetite is poor, and per mom, the teachers report that he is distracted during the class. The physician reviews the notes and plans to renew the stimulant prescription with an increased dosage. So we've got a moderate amount of the complexity of problems addressed, because this is a chronic condition that is worsening. The amount and complexity of the data is low because we have only 1 independent historian, and the risk of and complications or morbidity to patient management is moderate because of the prescription medication. Next slide. And another moderate complexity scenario with a 48-year-old female with a long history of anxiety and depression follows up for her medication adjustment. And this could be a behavioral health scenario. So it complains that she has missed work, is unable to sleep, and is emotional with crying episodes most days. She worries about the pandemic situation, has been washing her hands 15 times a day. She denies suicide ideations and feelings of rage. The physician reviews previous progress notes and maintains her current Paxil dosage, but adds Cymbalta. So this is moderate complexity because of the amount and complexity of problems addressed is moderate because it's a chronic illness. It's a chronic condition that is worsening. We've got minimal data and complexity of data to be reviewed because there's no diagnostic tests or other historians involved. And then the risk and complications and morbidity is moderate because of prescription medication. Next slide. So now in this scenario, which would be high complexity for medical decision-making, it's an elderly patient who presents with a severe exacerbation of a chronic condition. He has extreme shortness of breath and chest pain and is accompanied by their daughter, who is a primary caregiver. The daughter describes compliance with current medications and progression of symptoms. Treatment plan includes the chest x-ray to rule out pneumonia, a CBC, and an EKG. The chest x-ray indicates pneumothorax and the ECG shows arrhythmia. Hospitalization is discussed for management with IV diuretics and cardiac observation. So this would be a scenario of high complexity to the number of problems addressed, high complexity of data to be analyzed, and then the risk of complication is considered high. Doesn't matter that the patient goes to the hospital or not, but the fact that it is discussed and that the management is discussed results in leveling this for medical decision-making at high complexity. Next slide. And we have one more, actually, please advance to the next slide. That's a duplicate slide, sorry. Now, just before we go to the question and answers, I want to remind everybody that you can still separately report services with your E&M service on the day of your E&M service, and that you would report these services with modifier 25. So one of the things that you can still do is if you have a patient that comes in for their routine checkup and then they present with problems, it's going to be much easier to separate the routine physical exam or routine checkup and to code for a level based on medical decision-making, because you no longer have to consider the history or physical exam associated with that medical decision-making to add that level of service, that level of E&M onto the routine preventative health care. So it's going to be much easier to report both services. Just make sure that you're clearly documenting your medical decision-making for the service that you reported in addition to a routine physical. And if you're reporting E&M services with modifier 25 on top of a diagnostic procedure where modifier 25 is required, say the patient comes in and you do a workup and then you decide to do a biopsy in-house, you would report modifier 25, but make sure that if you're documenting based on time, you exclude the time spent on that procedure or exclude the time on anything that you're doing diagnosis-wise that you're separately billing for. So if you're taking and doing an x-ray in-house and you're reading it, you're not counting it, you're billing for it separately, you can't count that in the time or in the medical decision-making when you're reporting your E&M service on the same date. Next slide. So again, you want to make sure that you are associating your orders and plan of care on your chart that it clearly matches with the E&M service that you're reporting separately on top of additional services. And again, if you're reporting an E&M service with routine preventative care, try to base it on the medical decision-making and not to use time so that it's more clearly demonstrated. Next slide. So real quickly, the RVU changes are supposed to be increased effective January 1st of 2021 so that the levels of service will carry a higher reimbursement than they did in previous years. And this table indicates that for established patients, there are more significant increased reimbursement where 99213 or the lower levels are actually getting the highest amount of reimbursement at 46% and 34%, I'm sorry, the highest increase to their payment levels as in previous years. Next slide. So to prepare for this change, it's just imperative that all your providers and staff need to know what the new guidelines are. If you have timeframes as part of your descriptors in your on your documents or in your notes, you want to make sure that those are all updated. You want to make sure that your templates no longer pulling in unnecessary history and exam and are no longer calculating on requiring those elements of the history and exam. You should review your timekeeping procedures to make sure that you have procedures and policies in place to capture all that time. You want to make sure that your EMR vendors have updated their medical decision-making calculators, and maybe there's going to be a cost to that. So you want to calculate any financial impact on your organization to putting these procedures in place, and also to make sure that your payers are going to be following these new guidelines as well. Next slide. So, and here's the link of resources that we've attached to you for further research and instruction and guidance. Now I think we're going to open it to questions. Next slide.
So just want to remind everybody that if you haven't yet done so, please put any questions in the chat box. If we do not get to them, we will post those questions on the website. But again, if you have any questions, please post them right now in the chat box. Marie, I do have a couple of questions for you.
Great.
So we'll start with those. A chronic illness that poses a threat to bodily function and quality of life. That's a broad, that's quite a broad array, especially in some specialties. What guidance, guidelines, recommendations can you give us regarding the use and appropriate documentation to reflect this chronic illness?
Well, the chronic illness was defined within the slides, and that was the verbiage taken from the AMA. So a chronic illness is an illness that is expected to last at least 6 months or the duration of the patient's life. So it can be any long-lasting, chronically recurring illness, chronic allergies, chronic ear infections, generally accepted terminology for the diagnoses. That would be, well, certainly one reference would be in the ICD-10 book. You know, they may add codes for an acute chronic serous otitis media, and there's a different code for chronic serous otitis media. So that's one set of guidance, but anything that is going to be requiring a condition that needs to be managed and someone needs to be maintained at a treatment goal for beyond 6 months to the rest of their life, I would say.
And then how would you define those conditions that pose threat to life or bodily function?
Well, that would be up to the provider to determine what are the consequences of foregoing treatment completely. For instance, an acute bladder infection could lead to kidney infection, which could lead to kidney failure. So I think you have to consider, like, what is the likelihood of that happening? If the patient is the kind of patient that won't take medications, the likelihood of that is going to be greater. So, I mean, in the sense that, you know, nobody dies of a bladder infection hardly, but it could happen if it could, you know, completely goes untreated, and if there are other compounding factors. So it's going to be up to the provider to determine, and, you know, what they think the level of risk is. And I think at the minimum that, you know, you have to consider that if treatment is necessary, at a minimum, it's going to be low risk, not minimal risk, if it needs some sort of treatment. And then you have to gauge how severely ill you think the patient could become if they didn't follow your instructions.
Okay, thank you. Next question is, do the new 2021 guidelines apply to telehealth visits?
Yes, they do. For when you're reporting telehealth services with this E&M code set, this is going to be the criteria for this code set. And even though the patient's in their home, you're using the code set that you're in the office. So this is the applicable code set. So you can apply it to telehealth. And as I mentioned before, it's now going to be easier to get to higher levels because you can just base it on the medical decision making.
Okay, thank you. Can you give examples of drugs that qualify for the intensive monitoring?
Well, antineoplastic drugs often are ones. I can think of some examples like other biologics to treat like rheumatoid disorders. There is a kind of an exemplary list of some types of drugs that I've seen on the internet that I will obtain, and I will put that that list on the attached with the documents that we're posting afterwards for your reference.
Thank you. And then it says, during an encounter, a provider orders labs for an upcoming physical exam in 3 months. When do you take credit for the labs that are being ordered, now or later?
If you've ordered them at a visit for the visit 3 months down the road, you would count them at the time you order them. If the patient schedules an appointment for their follow-up and you're looking at your schedule ahead of time, or and the nurse advises you a patient wants to come in for their follow-up, and you say, oh, I want to get these labs before they come in, then you can get the points for reviewing those results when they come in for the follow-up because you've already ordered the tests. You just can't double dip on the same tests. And that's been a concept that Denise and I between ourselves have discussed. But if they're ordered by you, but not in connection with another visit, you can count for them. But if they're ordered by you and you've counted them at that earlier visit, you cannot count them again when you review the test results.
Okay. So are there any other questions out there for this webinar? I know that was a lot of information, and thank you, Marie, you did a great job. It's a tremendous amount to digest all at once, but if there are any other questions, we still have a little bit of time to take questions.
Thank you again, Marie and Denise. That was a very informative session. We suspect that some of you are going to have questions after the webinar, and Marie and Denise have very graciously agreed to answer any post-briefing questions you might have. You can email them directly. Their email addresses are on the screen. And if there are no additional questions right now, as a final reminder, please fill out the survey that will appear as you try and close out the screen. Thank you again. Stay safe and happy holidays to everyone.
Thank you.